Sugar is a villain even for bad breath. It feeds bacteria. Here's why. You do the routine. Brush, maybe floss, rinse with mouthwash. Yet sometime later, the breath that greets you in the mirror, or that someone awkwardly avoids, still feels off. That disconnect is common, because the mouth isn't just teeth and gums, it's an ecosystem. In that ecosystem, the fuel you offer matters. Sugar and other fermentable carbohydrates are the gasoline for many oral bacteria, and when those microbes eat, they release volatile sulfur compounds and other stinky byproducts. Cutting that fuel can be one of the highest impact moves you make to improve breath, but it's rarely the only step. Let's walk through how sugar fits into the story, how to quickly check where the odor is coming from, and a safe, targeted 48-hour trial you can try at home to get real clues and measurable change. You'll get practical checks you can do in plain light, a focused 2-day plan that centers on reducing sugar plus simple hygiene and saliva-supporting measures, and an explanation of the biology so the why makes sense. We'll also flag when the problem goes beyond home care and needs a dentist, a periodontist, or an ENT. This is clinical, practical, and framed around the big idea. Sugar feeds the bugs that make breath worse. It doesn't act alone, but it's a modifiable factor you can control quickly. First, the reality check. Why brushing alone often isn't enough. Brushing fights plaque on tooth surfaces and helps remove food debris, but many of the main odor sources hide where a toothbrush doesn't reach. Think of 4 common reservoirs that keep bad breath alive. Tongue coating. The back of the tongue is textured and traps dead cells, mucus, and bacterial biofilm. That coating is a major source of volatile sulfur compounds, VSCs, the rotten egg-smelling gases produced by bacteria metabolizing proteins and other substrates. Periodontal pockets. In moderate to severe gum disease, bacteria live deep in pockets around teeth in thick biofilms that are hard to disrupt with routine brushing. Tonsil crypts and tonsil stones. The folds and crypts of the tonsils can trap debris that calcifies, creating small stones that harbor odor-producing bacteria. Dental restorations and appliances. Gaps around crowns, bridges, implants, or dentures can trap food and biofilm, supporting local bacterial growth. Add to that systemic contributors and lifestyle factors, dry mouth for medications or dehydration, smoking, alcohol, certain diets, and systemic illnesses, and you see why bad breath is often multifactorial. Sugar doesn't cause every case, but it consistently makes the environment more hospitable to bacteria that produce foul-smelling compounds. When those bacteria have plentiful sugar, they form denser biofilms, generate more metabolic byproducts, and the problem can persist despite regular brushing. Before we go deeper into mechanisms, try 3 quick self-checks.
These are simple, immediate, and informative. Do them in good light, with clean hands and a clean spoon or gauze if you have it. First test, the tongue scrape smell test. Stick out your tongue and look at the back third where the surface is rougher. Use a tongue scraper or the flat edge of a spoon to gently scrape from back to front once or twice. Smell the scraped material on the spoon or scraper. If the odor on the scraper is distinctly stronger than your typical breath, the tongue coating is likely a primary contributor. This kind of smell tends to be sulfurous and often improves within a few days if the tongue coating is reduced and you decrease available sugars. Second test, the floss or gauze smell test. Take a long piece of floss and run it between a few teeth, or wipe a small square of clean gauze around the gum line and under contacts. Smell the floss or gauze. A strong, unpleasant smell here often points to trapped debris or periodontal pockets rather than just the tongue. When flossed surfaces smell worse than the tongue scraper, think pockets, food impaction, or restorations that trap plaque. Third test, the visual tonsil check. Use a mirror and a light. Tilt your head back, say ah, and look at the back of the throat. White or yellowish pebbles in the tonsil crypts, sometimes called tonsilliths or tonsil stones, are visible in many people and can harbor odor-causing bacteria. Visible stones are an easy-to-spot reservoir. They often produce a localized, sharp, fishy, or sulfurous smell. If you see anything that looks inflamed beyond small stones, or if examining your throat causes pain or bleeding, stop and seek clinical evaluation. If one or more of these tests point strongly to a single reservoir, you're already closer to a targeted plan. If nothing obvious shows up, that's also useful information. It shifts the focus towards sinus or systemic causes, or deeper dental disease that needs professional assessment. If this is resonating, type 1 in the comments and subscribe so you don't miss the hands-on demo later where we show techniques step by step. Now let's look at the biology in plain terms, what sugar actually does inside your mouth. Oral bacteria are metabolically diverse. Some prefer proteins, some can ferment sugars, and many can use a mix of substrates. When we talk about sugar here, we mean added sugars and other fermentable carbohydrates that bacteria can break down relatively quickly. Table sugar, high fructose corn syrup, sugary drinks, candy, and frequently consumed high-starch snacks.
Fruit juices, sports drinks, and even certain carbohydrate-heavy processed foods can behave like sugar in the mouth because they provide easy fuel. How that fuel translates to bad breath happens through two interrelated processes. First, fermentation and VSC production.
Certain bacteria degrade sulfur-containing amino acids, the building blocks of proteins, to produce volatile sulfur compounds, such as hydrogen sulfide and methyl mercaptan. These molecules smell strongly of rotten eggs or cabbage. Sugar doesn't directly turn into VSCs, but sugar consumption changes the environment. When bacteria have access to simple sugars, they can grow faster, increase biofilm production, and create microenvironments where protein breakdown is amplified. In other words, sugar feeds the general bacterial population and allows sulfur-producing species to flourish or to be more metabolically active. Second, sugar promotes plaque and biofilm maturation. Biofilms are communities of bacteria embedded in a matrix they build. Sugars are substrates that microbes convert into extracellular polysaccharides, sticky substances that help the biofilm adhere and densify. A thicker, more mature biofilm offers protected niches where oxygen is low, and anaerobic bacteria that favor protein breakdown and VSC production thrive. When plaque becomes denser, it resists casual brushing and provides reservoirs for ongoing odor generation. There's also a specific connection between sugar and the tongue. The tongue's rough surface traps debris and a mix of saliva, dead cells, and bacteria. If your diet consistently provides sugars, the tongue coating becomes richer in bacterial biomass and extracellular matrix, making it smellier. Reducing sugar intake reduces the substrate those bacteria rely on, and coupled with mechanical removal, scraping, you can see noticeable improvement quickly. Xylitol deserves a brief mention here because it's a practical sugar substitute that shows benefit in oral hygiene contexts. Xylitol is a sugar alcohol that many common karyogenic bacteria cannot ferment effectively. Chewing xylitol gum after meals increases saliva flow, which helps clear food and buffer acids. While xylitol is not a cure-all, substituting sugar-containing mints or candies with xylitol gum or lozenges can reduce the immediate fuel available to bacteria and support saliva-driven clearance. Be cautious. Xylitol can cause gastrointestinal upset in some people if consumed in large quantities, and it's extremely toxic to dogs. Keep any xylitol-containing products safely away from pets. A balanced way to think about sugar. It's a major fuel source that promotes bacterial growth and biofilm resilience. Reducing added sugars, avoiding sugary snacks between meals, and choosing non-fermentable alternatives like xylitol where appropriate are high-impact behaviors. But sugar's influence is one part of a system that also includes saliva flow, oral hygiene, existing dental disease, and anatomical reservoirs. So the most effective approach combines dietary change with hygiene and targeted medical evaluation when needed.
That brings us to a practical, time-limited trial you can do at home. A 48-hour targeted test designed to reduce sugar exposure and support mechanical removal and saliva, with simple monitoring to tell you whether the likely reservoir is tongue-related, periodontal, or something else. Why 48 hours? Because tongue coating-related odors often shift within days, and a short, focused trial gives you a quick signal. If breath improves markedly in 48 hours, tongue coating and substrate reduction are likely contributors. If there's no noticeable change, the issue might be deeper, periodontal pockets, dental restorations, or extraoral, sinus, tonsils, or systemic, and that guides next steps. Here's a step-by-step conservative 48-hour plan. It's safe for most adults, doesn't require stopping prescribed medications, and is designed to generate information as much as to produce symptom relief. Before you start, establish a simple log sheet. For 2 days, record time, what you ate or drank, a breath score on a 1 to 10 scale, where 1 is neutral and 10 is extremely bad, medications, and any tongue scraper or floss events. This data helps you and your clinician later. Day 0, baseline evening. Do the 3 quick self-checks so you can document the starting pattern: tongue scrape smell, floss or gauze smell, and tonsil visibility. Note which test smelled worst and your baseline breath score. Then, the 48-hour protocol. 1. Sugar reduction, primary pillar. Avoid added sugars and sugary drinks. That means no soda, fruit juice, candy, sweet pastries, or sugary coffee drinks. Minimize starchy snacks between meals. If you need a sweet option, choose a small amount of fresh fruit during meals rather than fluid fruit sugars between meals, or consider xylitol gum after meals. Dosage: chew for 5 to 10 minutes. Stay with manufacturer guidance. Avoid if you have known intolerance. The point is to deprive oral bacteria of ready fuel, especially between meals. 2. Tongue cleaning twice daily. Use a tongue scraper or the back of a spoon to gently clean the dorsal surface of the tongue in the morning and once before bed. Don't scrape so hard that it causes gagging or bleeding. Gentle, repeated passes are effective. If the initial tongue scrape smelled strongly, add a midday scrape after lunch. 3. Interdental cleaning once daily. Use floss, interdental brushes, or a water flosser once a day to disrupt biofilm in interdental areas. Pay special attention to sites where floss smelled strongly at baseline. 4. After meal water rinse and saliva stimulation. Rinse the mouth with plain water after meals and chew sugar-free gum, preferably xylitol containing, to stimulate saliva if you tolerate it. Increased saliva reduces retention of food particles and buffers environments that favor anaerobic bacteria. 5. Short alcohol-free mouthwash once daily.
Use an alcohol-free antiseptic rinse once a day for up to 48 hours if symptoms are significant, but keep this brief and avoid long-term reliance. Avoid recommending chlorhexidine for extended use without clinician oversight due to potential staining and microbiome disturbance. If a clinician prescribes it, follow their directions. 6. Gentle saltwater gargle twice daily. A warm saline gargle can help dislodge superficial debris in the throat and tonsil region. Dissolve half a teaspoon of salt in 8 ounces of warm water and gargle for 15-30 seconds. Do not swallow. This is a conservative, low-risk measure to help with throat hygiene. 7. Hydration and medication review. Drink enough water throughout the day to avoid dry mouth. Do not stop any prescribed medications. Instead, document any agents that might dry the mouth, antihistamines, certain antidepressants, diuretics, and discuss these with your clinician if they're likely contributors. 8. Avoid alcohol and smoking during the trial. Both can dry mucosa and worsen odor. During the 48 hours, use your log to note breath scores and which interventions you did and when. Redo the tongue scrape and the floss gauze test at the end of 48 hours under the same conditions as your baseline. Improvement in tongue scrape odor within 48 hours strongly suggests tongue coating as the primary source. Marked improvement in floss smell suggests plaque and interdental biofilm control is helping. Little to no change suggests you may have deeper periodontal disease, a problematic restoration, or an ENT source that needs evaluation. Safety notes and boundaries while doing this trial. Do not attempt forceful manipulation of tonsil stones with sharp objects. If you notice bleeding, severe pain, fever, breathing or swallowing difficulty, or systemic symptoms like unexplained weight loss, stop the trial and seek medical attention. If you use over-the-counter antiseptic rinses and notice increased irritation, taste disturbances, or persistent staining, discontinue and consult your clinician. It helps to set expectations. If the tongue is the main reservoir, many people notice subjective improvement within 48 hours to a few days if they reduce sugars and consistently remove the coating. For periodontal pockets or deep restorations, meaningful change typically requires professional care, scaling, root planing, or repair, and improvement unfolds over weeks to months. Tonsil stones that are small and superficial sometimes respond to saline gargles and improved oral hygiene. Recurrent or deep stones often need ENT evaluation. Let's pause for a quick mini hook. If your tongue scrape smelled worse at baseline and it improves in 48 hours, you're in the fastest lane to breath improvement. If not, the next sections will guide how to identify and manage the other reservoirs. To make the 48-hour trial more likely to work, here are some practical tips you can adopt immediately. Avoid sugary snacks between meals.
Bacteria thrive on frequent feeding. If you snack frequently, consider replacing snacks with protein or fiber-rich options that do not leave simple sugars on tooth surfaces. Time your last sugary meal well before bed. Nighttime is when saliva production naturally drops. A sugar-rich late snack creates a long, undisturbed window for bacterial metabolism. Replace sugary mints or candies with xylitol gum after meals, if you tolerate it and have no animal exposure. Small doses after meals are helpful because they both eliminate sugar and boost saliva. Use a tongue scraper that's comfortable for you. Metal or plastic scrapers both work. The key is gentle, consistent use. Keep a small notebook or use a notes app to record 2 things: the worst smelling test, tongue, floss, or tonsils, and your 1 to 10 breath score at consistent times, first thing in the morning, mid-afternoon, and before bed. Consistent measurements make changes easier to see. Mechanistically, you're doing 2 things in the 48-hour trial: reducing substrate for bacterial growth and physically disrupting the reservoirs where those bacteria live. That combination, starve and scrape, is why many people see a measurable difference quickly. But remember, if there is established periodontal disease or a defective restoration, the bacterial communities live deeper and protected inside biofilms that need professional disruption. Now let's begin to look more closely at each reservoir so you can interpret test results and decide the likely next step. Start with the tongue. The dorsal surface of the tongue has papillae, tiny projections that increase surface area but also trap debris. Tongue coatings vary from a thin white film to a thick yellowish or brown layer depending on diet, oral hygiene, tobacco use, and systemic factors. When a tongue scrape smells strongly, the likely culprits are anaerobic bacteria breaking down proteins and producing VSCs right on that surface. In people whose dominant issue is the tongue, reduction in dietary sugars plus regular scraping and saliva stimulation often reduces odor significantly within days.
Signs that point to a tongue-dominant problem: strong odor on a tongue scrape that's far worse than on floss, visible coating at the back of the tongue, improvement reported after scraping in prior attempts, and a history of frequent sugary snacks or dry mouth. If the tongue is central, treatment focus is mechanical, tongue scraping, and behavioral, cut sugar between meals, stimulate saliva. Periodontal pockets deserve their own attention because they're common and frequently under-recognized. When gums are inflamed and pockets form, anaerobic bacteria colonize those deeper spaces and produce VSCs consistently. A strong smell on interdental floss or gauze often signals periodontal involvement.
Sugar contributes here by helping plaque mature into a denser biofilm. Frequent sugar exposure favors shifts in the microbiome toward more pathogenic communities. For periodontal-related halitosis, home measures like interdental cleaning and sugar reduction help, but professional scaling and root planing or periodontal therapy is often required to reach lasting control. Visual and clinical clues that point to periodontal involvement include bleeding on probing, gums that pull away from teeth, mobility, persistent bad taste, and floss that smells worse than the tongue scrape. Improvement after a professional clean generally takes weeks. You should expect slower change than tongue-dominant cases. Dental restorations, crowns, bridges, implants, large fillings, and removable appliances can create niches where food and bacteria accumulate. Poorly fitting margins or cracks can harbor biofilm behind restorations where home care can't access effectively. If you suspect restorations, perhaps you notice persistent odor localized around a particular tooth or crown, or you recently had restorative work and started to notice breath issues, a dental exam, including checking margins and radiographs, may be needed. In many cases, repair or replacement of the restoration removes the reservoir. Tonsil crypts and tonsil stones sit in the throat and behave differently. They often produce a localized, sometimes pungent smell. Visible stones may be small white or yellow nodules lodged in the tonsil folds. Conservative measures include saltwater gargles and gentle non-invasive rinses. If stones are superficial, they may dislodge with improved hygiene and gargling. If stones recur frequently, cause pain, bleeding, or breathing difficulty, or if they're deeply embedded, ENT evaluation is warranted. An ENT can discuss options ranging from manual removal in clinic to more advanced interventions if stones are recurrent and symptomatic. A critical safety note: do not use sharp objects, cotton swabs jammed into tonsil crypts, or forceful manipulations at home. Aggressive removal risks bleeding, infection, and scarring. If you or someone you care for attempts home extraction and experiences pain, bleeding, or worsening symptoms, seek professional care. We're at a point where you've learned the simple checks, you've seen why sugar matters biologically, and you have a concrete 48-hour plan to try. Many viewers will see a rapid signal. Either the breath improves and the tongue was likely central, or there's little change and deeper dental or ENT causes should be considered. But real-world cases are often mixed: tongue plus pockets plus intermittent postnasal drip. And that's where structured follow-up and clinician collaboration matters. To make this practical, let me introduce 3 composite cases you'll meet in more detail later. Brief sketches to illustrate how sugar plays into different patterns.
These are composites built from common clinical stories, meant to illuminate rather than to substitute for individual evaluation. Anna. She snacks frequently through the day on sweet granola bars and sips a sweetened iced coffee each afternoon. Her tongue scrape at baseline smells strongly, more so than floss. She has a thin white coating at the back of her tongue and reports dry mouth at night. For Anna, the combination of sugars between meals, decreased overnight saliva, and inadequate tongue cleaning likely creates an environment where a tongue-dominant odor develops. A focused 48-hour trial cutting sugar between meals, adding twice-daily tongue scraping, increased hydration, and xylitol gum after meals may yield quick improvement. Marcus. He's in his late 40s, smokes occasionally, and reports bleeding gums. His floss smells strongly at baseline, and he has pockets on dental exam. Marcus's diet includes frequent sweets, but the defining problem is periodontal disease. Sugar has likely worsened plaque maturation, supporting pathogenic biofilms in pockets. For Marcus, home measures are necessary and worthwhile, but professional periodontal therapy will be essential to reduce pocket depths and achieve reliable breath control. Leah. She has chronic sinus congestion and a history of seasonal allergies. Her home checks show minimal tongue coating, and the floss doesn't smell strongly, yet she notices an intermittent foul smell, particularly when she wakes up or during sinus flares. Postnasal drip can feed bacteria in the oropharynx, and sugary drinks during the day can worsen the overall microbial load. But Teresa's primary issue lives in the sinonasal space.
ENT evaluation, imaging, and targeted sinus treatment are often the right path for cases like Leah's, though the 48-hour sugar-focused trial can still help reduce oral substrate that exacerbates secondary bacterial growth. These vignettes show how sugar is a recurring amplifier across different reservoirs. Cutting or substituting sugar rarely solves every case by itself, but it reduces one of the major modifiable drivers and often speeds the benefit of other interventions. We'll pick up next by walking through precise technique for tongue scraping, the exact way to do the floss-DAWS smell test safely, and the clinician scripts you can bring to your dentist, ENT, or PCP, short, copy-ready notes that make appointments more efficient and diagnostic. We'll also map the expected timelines more granularly, what to expect at 48 hours, at 2 weeks, and at longer follow-up, and how to interpret incremental changes in your log. But before that, there's an important set of caveats and red flags to review, so you don't mistake a benign smell for something that requires urgent attention. Now let's get practical about doing the things that make a difference and about what to expect next.
We'll start with exact, safe technique for tongue scraping and the floss-gauze smell test, so you can collect reliable information at home. Then I'll walk through the realistic timelines for different causes, the next step clinical evaluations you might need, and the language you can bring to a provider. I'll close with the follow-up plan, what success looks like at 48 hours and at 2 weeks, and 3 composite follow-ups, one for Anna, one for Marcus, and one for Leah, so you can see how these steps play out in real life. How to scrape your tongue safely and effectively. Stand in front of a mirror in good light. Stick your tongue out far enough to see the back third, but not so far that you gag. Use a purpose-made tongue scraper if you have one. If not, the rounded edge of a clean spoon is fine. Place the scraper or spoon as far back on the tongue as you comfortably can without triggering severe gagging, and drag it forward to the tip in a single gentle pass. Rinse the scraper or spoon under running water, then repeat once or twice. The goal is gentle mechanical removal of the coating, not aggressive abrasion. If you feel any pain, bleeding, or marked irritation, stop and switch to lighter passes or consult a clinician. After scraping, smell the scraper or spoon to see whether the odor is strong and sulfurous. That gives you the diagnostic clue. Clean the scraper after each use and let it dry between uses. Do the scrape in the morning and again at night. If the initial scrape produced a strong smell at baseline, add a midday scrape after lunch during your 48-hour trial. If you have a sensitive gag reflex, try leaning forward when you scrape rather than tilting your head back. That often reduces the reflex. If scraping provokes persistent bleeding or pain, stop and bring that finding to your dental provider. How to perform the floss or gauze smell test. Use a single long piece of floss and run it carefully between several pairs of teeth, ideally in areas where you suspect trapped food or where you have noticed recurrent problems. Alternatively, fold a clean piece of gauze into a small pad and wipe gently along the gum line and under contacts just once. Remove the floss or gauze and smell it. If the smell is distinctly worse than the tongue scrape, think periodontal pockets, trapped debris, or problematic restorations. Record which sites produce the worst odor. If you notice bleeding on flossing, write that down as well. Bleeding with a strong foul odor makes periodontal disease more likely. Don't push floss aggressively into painful areas. The aim is diagnostic sampling and gentle disruption, not causing trauma. How to check the tonsils safely. Use a bright light and a mirror. Tilt your head back, say ah, and look for white or yellowish nodules in the folds of the tonsils. Small superficial stones may come into view.
If they're visible and you can gently gargle them loose with warm salt water and expel them into the sink, that is a conservative, low-risk approach. If you can't dislodge them easily, if manipulation causes pain or bleeding, or if stones recur frequently and cause symptoms, seek ENT evaluation. Avoid forceful prodding, poking with objects, or aggressive home extraction. These actions can cause bleeding and infection. If a stone is large, deeply embedded, or associated with swelling or difficulty breathing or swallowing, go to urgent care or the emergency department. What to expect during and after the 48-hour trial, and how to interpret the changes. Your log is central. Every entry matters. For each meal or snack, note the time, what you ate or drank, whether you chewed xylitol gum afterward, and your breath score at consistent times, for example, upon waking, mid-afternoon, and before bed. Record the results of your tongue scrape and floss gauze test at baseline and after 48 hours under similar conditions, same time of day, no eating or drinking for at least 30 minutes prior. If the tongue scraper smell improves markedly within 48 hours and your subjective breath score drops several points, that's a strong signal that tongue coating and available oral sugar were major contributors. If the floss gauze smell improves, but the tongue scrape doesn't, you may be making progress on interdental biofilms, but may still have persistent tongue-associated odor. Keep scraping and reducing sugars because both will help. If there is little to no change in either test,
The problem is less likely to be purely tongue coating driven and more likely to reflect periodontal disease, a failing restoration, tonsillar disease that is not superficial, or an extraoral source such as sinus disease or a systemic condition, all of which need clinician evaluation. What to do next depending on your pattern. If the tongue scrape was the primary positive test and you see improvement, continue the sugar reduction behaviors, tongue scraping twice daily, after meal rinses, and xylitol gum is tolerated for the next 2 weeks. Expect continued incremental improvement over days to a couple of weeks. If the intradental floss smells strongly, but tongue scraping is less dramatic, continue daily intradental cleaning and schedule an appointment with your dentist to evaluate periodontal status. If you have visible tonsil stones that don't respond to conservative measures or entrapments accompanied by pain, bleeding, or repeated infections, request an ENT evaluation. If none of the home tests are suggestive and you have other symptoms, persistent sinus congestion, facial pressure, chronic cough, unexplained weight change, excessive thirst, or changes in urination, contact your PCP for a systemic workup while also keeping dental and ENT as possible partners. A realistic timeline checklist helps manage expectations.
On day 2, many people with tongue-dominant halitosis notice a meaningful subjective improvement if they've reduced sugar and scraped the tongue. By day 7 to 14, a fuller behavioral program, consistent tongue scraping, interdental cleaning, reduced added sugar, and saliva-stimulating behaviors often brings further measurable gains. If the problem is periodontal, professional therapy such as scaling and root planing typically begins to show an improving oral environment over several weeks, with breath benefits commonly seen after the acute inflammation is addressed. Full tissue recovery may take months and often requires maintenance. Tonsil stones that are small and episodic may respond to saline gargles and improved oral hygiene over weeks, but recurrent symptomatic stones sometimes require ENT interventions. Resolution timelines vary. Sinonasal causes may need weeks of targeted medical therapy, such as topical steroids or saline irrigations, and if structural issues exist, surgical timelines vary with diagnosis and decision-making. Systemic conditions require whatever timeline the treating clinician sets for testing and treatment. Breath changes here follow systemic correction and are not typically resolved by oral hygiene alone. Dental and periodontal evaluation, what your clinician will likely assess. When you see your dentist or a periodontist, expect a focused history and targeted exam. They will want to know your 48-hour log results, which tests smelled worst, and what you've tried. Common next steps include a full-mouth periodontal probing chart to measure pocket depths and bleeding on probing, a visual and tactile exam of restorations and margins, and radiographs to check bone levels and hidden pathology. If pockets are present, scaling and root planing, deep cleaning, and improved home care are the standard first-line treatments, with adjunctive therapies considered on a case-by-case basis. If a specific tooth or restoration is suspected, the dentist may recommend repair or replacement to eliminate trapped niches. Smoking cessation and reducing sugary habits are often part of the long-term plan. Antibiotics are not routine for halitosis alone, but may be used judiciously for active periodontal infections. Decisions about antibiotic use are individualized. ENT evaluation, what to expect and what they may look for. If your home checks were negative or if you have throat symptoms, chronic postnasal drip, recurrent tonsillitis, or visible tonsil stones that are recurrent and symptomatic, an ENT will often perform a nasal endoscopy to look at the nasal passages, nasopharynx, and larynx. Imaging, typically a CT scan of the sinuses, may be ordered if chronic sinusitis is suspected.
For tonsil-related problems, an ENT can examine the tonsils more thoroughly and remove stones in office under appropriate conditions, or discuss options ranging from conservative symptom control to more definitive surgical approaches when stones or infections are recurrent and symptomatic. Medical management for sinus disease may include saline irrigations, topical nasal steroids, and, when indicated, antibiotics or allergy-directed care. An ENT will discuss benefits and risks of any procedural option. Surgical decisions are individualized and not trivial, so they require careful clinical justification. Systemic causes in the role of your primary care clinician. Systemic conditions that can change breath include diabetic ketoacidosis, which produces a fruity or acetone-like smell and is typically associated with high blood sugars, dehydration, and other systemic signs. Uremia from advanced kidney disease, which can give an ammonia-like odor, and advanced liver disease, which may produce a musty, sweet odor. Gastroesophageal reflux can create a sour or acidic smell and is often accompanied by heartburn or regurgitation. If you have systemic symptoms, unexplained weight loss, night sweats, ongoing fever, persistent cough, significant thirst and urination changes, or new neurologic signs, contact your PCP. The PCP will consider blood tests, such as glucose, basic metabolic panel, liver function tests, and other targeted workups based on your history. Remember that these systemic causes are often accompanied by other signs, so breath changes alone rarely imply a systemic illness. The full clinical picture matters. Safe handling of tonsil stones and why caution matters. We've already said not to use sharp instruments at home. To experiment on safe steps,
Gentle saline gargles after meals and upon waking can dislodge surface debris and reduce local bacterial load. A warm salt water rinse is simple. Dissolve about half a teaspoon of salt into about 8 ounces of warm water and gargle gently for 15 to 30 seconds. Then spit. Repeat twice daily. Some people find that careful use of a low-pressure water irrigator, set on a gentle setting, can flush superficial tonsil debris, but this must be done cautiously and only if you're comfortable. Don't aim high-pressure streams directly into crypts, and stop if it causes pain or bleeding. If you have recurrent symptomatic tonsil stones, ask for ENT referral rather than trying to repeatedly excavate them at home. An ENT can remove them safely and discuss whether ongoing problems suggest a need for more definitive care. Medications, dry mouth, and other amplifiers. Many commonly prescribed medications dry the mouth and make bad breath worse by reducing saliva's cleansing and buffering capacity. Antihistamines, certain antidepressants, some antipsychotics, and strong diuretics are familiar examples. Many others are possible. Don't stop your medications on your own.
Instead, document them in your log and mention them to your PCP or dentist. They can review alternatives or strategies to mitigate dry mouth, such as focusing on hydration, using sugar-free lozenges, or considering saliva substitutes when appropriate. Smoking and heavy alcohol consumption both reduce saliva and damage mucosal defenses. If these are factors for you, addressing them will help breath and overall health. Xylitol specifics and practical guidance. Xylitol is a sugar alcohol that many oral bacteria cannot ferment well, and chewing xylitol-containing gum after meals can stimulate saliva while reducing immediate sugar exposure. Use 1 piece of xylitol gum for 5 to 10 minutes after meals if you tolerate it, adhering to manufacturer instructions. Many people use a piece after breakfast, lunch, and dinner. Don't exceed the recommended daily amount on the product label, and stop if you experience gastrointestinal upset. Store xylitol away from pets. Even small amounts can be fatal to dogs. If you have a medical condition that limits sugar alcohols or causes digestive sensitivities, check with your clinician first. Antiseptics and mouthwashes. Use them wisely. Short-term use of an alcohol-free antiseptic mouthwash can be helpful during a targeted 48-hour trial, but long-term reliance is not ideal. If a clinician prescribes chlorhexidine for a brief period, follow their instructions. Chlorhexidine is effective, but can stain teeth and alter taste with prolonged use. Overuse of strong antiseptics can disrupt the oral microbiome in ways that aren't helpful long-term. Alcohol-containing mouthwashes can dry the mouth and exacerbate halitosis for some people, so prefer alcohol-free formulations during this trial and discuss options with your clinician if you're unsure. When to escalate urgently. Stop the trial and seek prompt medical care if you experience high fever, difficulty breathing or swallowing, severe throat pain, profuse bleeding from the mouth or throat, or systemic symptoms such as rapid weight loss or night sweats combined with breath changes. These are red flags that require urgent professional assessment. Documentation tips that make clinical visits productive. Bring your log to appointments. Photograph visible tonsil stones with your phone in good light so you can show the clinician. Note which test smelled worst, what improvements you saw at 48 hours, and whether you had any bleeding or pain with home attempts. A sample short history you can hand to a provider might read, persistent bad breath for 3 months, completed 48-hour sugar reduction and hygiene trial, tongue scrape smell decreased from 8 out of 10 to 3 out of 10, floss/gauze smell unchanged, no fever or systemic symptoms. Medications, list here. Smoking, yes, no. Previous dental work, crowns on upper left molars, 2018. That level of detail saves time and helps the clinician focus on the likely reservoirs.
Clinician-facing, copy-ready scripts you can use when booking or during appointments. For your dentist or periodontist, patient reports persistent halitosis despite routine brushing. Completed a 48-hour sugar reduction and hygiene trial with tongue scraping twice daily. Tongue scrape smell decreased or unchanged. Floss smell decreased or unchanged. Bleeding on floss noted. Request periodontal probing, full mouth radiographs, evaluation of restorations and occlusal appliances, and recommendations for scaling and root planing as indicated. For ENT, patient with persistent halitosis and visible tonsil stones, photos attached, or with chronic postnasal drip despite nasal steroid trial. Request nasal endoscopy and evaluation of tonsillar crypts, consideration of in-office removal, and imaging if sinus disease suspected. For PCP, patient with persistent halitosis without clear oral source, no fever or systemic illness, but concerned about systemic contributors. Please review medications that may cause dry mouth, consider screening labs, glucose, basic metabolic panel, LFTs, as clinically indicated, and advise on referral to ENT or dental specialists. Follow-up plan you can use at home and with clinicians. After the 48-hour trial, if you improved, continue the behaviors and reevaluate at 2 weeks. Continue sugar reduction, tongue scraping twice daily, daily interdental cleaning, after-meal rinses, and xylitol gum as tolerated. At 2 weeks, compare your logs and repeat the 3 tests under similar conditions. If you show continued improvement, maintain the program and schedule routine dental care. If progress stalls or slips back, schedule the dental or ENT evaluation using the copy-ready scripts above. If initial home measures showed little improvement on the 48-hour trial, seek dental or ENT evaluation sooner rather than later. Bring your log and the results of the tests you performed. What success typically looks like. For a tongue-dominant problem, success often appears as reduced coating on the dorsal tongue, a marked drop in the tongue scrape odor, and a consistent subjective improvement in breath scores within days to a couple of weeks. For periodontal causes, success involves a combination of professional treatment and ongoing home care, with gradual improvement in bleeding, pocket depths, and breath scores over weeks to months. For sinus or tonsillar causes, improvement follows appropriate medical or ENT-directed therapy and may require longer courses of topical agents or procedural interventions. Above all, success is measurable. Use your log to document objective changes rather than relying only on subjective impressions. Now let's revisit our 3 composite patients to see these principles in action. Anna's update. After her baseline testing showed a strong tongue scrape smell and a history of frequent sugary snacks, Anna committed to the 48-hour trial.
She avoided added sugars, substituted xylitol gum for after-meal mints, scraped gently twice daily, and rinsed after meals. On day 2, she noticed her tongue scrape odor drop from an 810 to a 310 and reported her subjective morning breath improved similarly. At 2 weeks, she had reduced her between-meal sweets habit substantially and continued light tongue scraping. Her dental exam showed no significant periodontal pockets and only minor gingivitis. The clinician recommended ongoing daily scraping, maintenance of reduced sugary snacking, and regular dental cleanings. Anna's case shows that when the tongue is the dominant reservoir and sugar is a frequent fuel, behavioral change plus mechanical removal can yield rapid, measurable benefit. Marcus's update. Marcus's floss/gauze test smelled strongly at baseline, and he bled on flossing. His 48-hour trial produced mild short-term improvement in interdental odor, but no substantial reduction. He was referred to a periodontist who performed periodontal probing and radiographs and diagnosed moderate periodontitis. Marcus received scaling and root planing, was counseled on smoking cessation, and was placed on a periodontal maintenance program. Over the following months, his pocket depths improved modestly, bleeding decreased, and breath scores improved gradually. Marcus's case illustrates that sugar reduction helps, but that established periodontal disease requires professional therapy to eradicate deep biofilms and achieve lasting improvement. Leah's update. Leah's home checks didn't show a dominant oral reservoir. The tongue scrape and floss test were unremarkable, yet she noticed intermittent bad breath correlating with sinus flares. She did the 48-hour sugar reduction trial and noted only minimal oral changes, so she sought ENT evaluation. Nasal endoscopy and an imaging study revealed chronic sinusitis with postnasal drip. After a regimen of saline irrigations, topical nasal steroids, and an allergy-focused treatment plan, Leah saw a reduction in sinus-related odor. She also maintained sugar reduction and oral hygiene measures to limit the oral bacterial substrate, which helped reduce episodic oral overgrowth during flares. Leah's story shows how an ENT source can present subtly and how addressing both sinonasal disease and oral substrate produces the best outcome. A few final practical details before we close. If you wear removable dental appliances, clean them regularly as instructed. Evening soaking and morning brushing of appliances reduce reservoirs. For denture wearers, brushing the palate and tongue and cleaning the appliance nightly are especially important. If you have large or complex restorations, bring photos and notes to your dental appointment and ask the dentist specifically to check margins and contact points. If you take medications that dry the mouth and cannot be changed, ask about saliva substitutes, sugar-free lozenges, and scheduling hydration around doses.
If you are concerned about social interactions while you pursue a diagnostic plan, consider temporary measures like sugar-free mints with xylitol, used judiciously, and frequent water sips after meals. These can make social interactions more comfortable while you work on the underlying drivers. You've now got an evidence-framed understanding of why sugar is a villain in the ecology of bad breath, practical home tests that point toward the likely reservoir, a safe 48-hour trial centered on cutting sugar plus mechanical cleaning and saliva support, and clear guidance on when to involve dental, ENT, or medical colleagues. You also have clinician scripts that simplify appointments and a follow-up plan that gives you measurable checkpoints at 48 hours, 2 weeks, and beyond. If you want hands-on demonstrations of technique, gentle tongue scraping, the floss gauze smell test, safe saltwater gargling, and how to document findings, watch the hands-on demo linked next for step-by-step visuals.
If your bad breath persists despite following the trial and the 2-week follow-up, or if you encounter red flag symptoms, use the copy-ready clinician scripts in the description to book a visit with your dentist, periodontist, ENT, or PCP. Reducing sugar is one of the highest impact steps you can take right away, but it works best as part of a whole system approach that includes mechanical cleaning, saliva support, and clinician evaluation when needed. You don't have to accept persistent bad breath as normal. With targeted steps, careful logging, and appropriate referrals, most people find marked improvement and a clear plan for lasting control.